Welcome to another episode of the Health Talk with me, your host, Dr. Sagorika. And today we are diving into a fascinating and life-saving medical specialty, cardiothoracic and transplant surgery. The heart is often considered the engine of our body, and when it malfunctions, a team of highly skilled surgeons will sometimes repair it and even sometimes replace it. But how do heart transplants really work? What does cardiothoracic surgeons do beyond heart transplants? What are some of the common myths about their work? To help us answer these questions and more, I'm honored to have my friend, Dr. Pradeep Kaul, a leading cardiothoracic surgeon in UK, and with his vast experience and expertise, we will get a glimpse of the world of open heart surgeries and transplants. Welcome, Pradeep, to the Health Talk. I'm really honored to have you here.
Thank you, Sagorika, for inviting me and for your kind introduction. I'm one of the many transplant surgeons and not the world leading, you can say.
Thank you very much for coming into my show. So you are a cardiothoracic and a transplant surgeon. So what exactly does a cardiothoracic and a transplant surgeon do?
As you, Sagorika, will be aware, it's a broad field.
Right.
We deal with different, surgically treat different problems with the heart. Commonest, you must have heard, is people who have got blocks in their arteries in the heart.
Right.
And we can bypass those blocks. We also address...
That's the bypass surgery.
Bypass surgery, yeah.
Right.
Also, then, in India, it's very common for people to, particularly people from lower social strata who develop rheumatic fever.
Right.
And that can affect the heart valves. And also now India has got an aging population, so that gets degeneration of these valves over age, and they can either become very tight or become very leaky, and we replace them or repair them so that the valves function normally again. So that is main, like I say, bread and butter cardiac surgery. Over and above, there is aorta, that's the tube that connects the main pumping chamber of the heart and sends blood to the rest of the body. That can have disease in the wall, which makes it become enlarged. We call it an aneurysm, and these aneurysms can dilate or get enlarged to an extent where there is an impending danger of rupture. And if that happens, it's quite catastrophic. People often die because of that. So that is another subspecialty of cardiac surgery.
Okay.
Yeah. So basically, this is broadly what we do.
And plus you do cardiac transplants.
Yes, that is like my subspecialty.
Okay.
So I do heart transplants, heart lung transplants, and something called as mechanical circulatory support. That means we use heart pumps to support the failing hearts. That is another dimension to my practice.
Right. So you said you are doing heart transplants, and heart transplant does sound like a absolute last resort for a person. We get scared. The moment we see anything related to heart, people will get scared very easily. And when you're talking about transplant, then it's a completely different ballgame. So who are the people who actually need a transplant?
Basically, heart transplant is a therapy for people who have got what is called as advanced heart failure, who don't have any other means. Like those are the patients, we can't do valve surgery, we can't do bypass surgery for them, or we can't actually put them on medication to prolong their life.
So when you say heart failure, what exactly does it mean? There is a heart attack, which people understand.
Yeah.
And you're using another term, heart failure. So what is a heart failure and why would they need it?
Heart failure actually is where the pumping function of the heart is grossly compromised, that enough blood is not pumped out of the heart to send around the body to meet the demands, like oxygen or nutrient demands by the rest of the body. So when we can't meet those demands because of the heart dysfunction, that is what is heart failure. Now, heart failure can be what we call compensated and decompensated. In compensated heart failure is where there is still enough blood going around the body to keep the person going, but they get limited in their day-to-day activities. These people learn to live around their disease. So they will not be very mobile, very active. They just are at home and just try to potter around rather than want to lead a full life they were leading before.
So any kind of activity would make them breathless or...
Predominantly breathless or, because their heart muscle has become scarred, so they rarely get chest pain.
So is this also the same term which is used as cardiomyopathy?
That's correct. Yeah. Cardiomyopathy is basically any disease of the heart muscle.
Okay.
So that can be because of lack of blood supply. That's called ischemic cardiomyopathy.
Right.
That can be, we sometimes don't know why the heart muscle has become thin and dilated. And that is called dilated cardiomyopathy. But as the gene mapping is getting more and more advanced, we are able to find out certain genes which can be inherited.
Okay.
So there are genes that over time makes the heart muscle weak. Even if patients haven't had a heart attack, it makes the heart muscle weak, and then it's not able to pump as effectively.
So it is like a, elastic, losing it, elasticity.
Elasticity, yeah. It's just that elastic is stretched so far.
The muscle normally has an elasticity, and that is lost.
It's not able to, relax and contract properly. Let's put it that way. And there are other things where people have thick heart muscle. That's called hypertrophic obstructive cardiomyopathy. Initially, the heart muscle kind of overcomes this resistance which is there in the, if I have to explain in detail, is that where actually the blood ejects out of the left ventricle, the main pumping chamber of the heart. That is where the obstruction is. And initially, the heart kind of copes with it, but over time it gets tired. Heart can cope, and patients don't have so much symptoms.
Right.
But later on, we call it burnt-out hypertrophic cardiomyopathy.
Right.
Yeah.
So because of the bigger size of the muscle itself is not getting enough blood supply to work.
To work, that happens, and then also, it has to work overtime, and it can only do so much. It gets tired in the end.
Right.
It's like flogging a horse. You can only do that for 6 months.
You can only do that. So.
And those are the patients now, because you asked me that which patients are eligible for transplantation. Now the advances in medical therapy are so much that we can maintain these patients for a long time on medication with reasonable symptom control.
Oh, that's good to hear.
Yeah. And what happens subsequently is that these patients are referred to a heart transplant center where they are actually kept under surveillance by the heart failure team.
Right.
And then we do a battery of tests and then see that, if you were to calculate their 1 year or 2 year survival, there are various scores in heart failure scores, and they tell us that this patient, what is the chance of him living for 1 year, 2 years, and then weigh the pros and cons of doing a transplant. If we see most of the best transplant centers are what transplants the mortality from a transplant operation is about 10%.
Only
at 1
10%.
year. Yeah, 10% at 1 year. In my center where I work, we have a 91% survival at 1 year, and 50% of those patients live for 14 years after that. So you can add a very good quality and amount of life to these patients.
Right.
But the important thing is that we want to take these patients to such a time where they need a transplant so that they can spend maximum time with the new heart on the other side of transplant.
Right.
So it's not good to prematurely transplant patients.
True, very true. So one more thing which I wanted to ask you is, as you were talking to me earlier, that you have worked in different countries.
Yeah.
You have studied from India, then you have worked in UK, you have also worked in USA.
Yeah.
Any kind of differences you have found in the kind of treatment protocols in different countries?
I think when it comes to super specialty medicine, there is not a different protocol. Everyone wants to do the same for the patients.
Okay.
But if you see like in US, where the resource is a lot more than in UK, you can see that they put a lot more pumps I was talking about earlier on in patients for destination therapy, whereas UK doesn't have a destination therapy program, and that's simply because of resource limitation. The good thing about heart failure is that it only takes a very small fraction of healthcare budget because there are not so many patients who get this treatment. Because if you let every patient have this complex and very costly treatment, like in US or in places like India where people may resort to insurance for their healthcare, the insurance companies may get bankrupt. So, so it is a balance between, there is no difference in the actual protocols or treatment protocols.
Right.
And it's that how you apply them and how liberally you apply those.
So it's question of affordability of the patient and plus availability of maybe the donors to provide the transplant things. So that's a big separate issue. Yeah, we will talk about it. Yeah. But that also different places have got different setups.
Definitely, yeah. There are different healthcare systems cater in their own way to their population.
We'll come to that. So as a surgeon, what kind of challenges do you face during a surgery?
I think people don't realize, and cardiac surgery is one surgery where the immediate outcome of your complication can be death. Though it's not very prevalent, like we can very safely do surgeries with very low mortality, but we always think that it could be around the corner. So till the patient is not weaned off the bypass machine, which we use to support our surgery, or till they don't get well after going home, we never feel happy about that patient's progress, that till they have not gone home. What are the challenges? Challenges are, if you see, they are long hour surgeries. Like my easiest surgery will last for 3 to 4 hours.
The easiest one.
The easiest one.
All right.
And the most difficult surgeries when I'm doing a transplant on somebody who's had this pump in before or who has had multiple surgeries done in the past, just to get into the chest and be able to put them on bypass machine, which I mentioned, can take 2-3 hours. The rest of the transplant, and then it comes to bleeding stopping after that. I sometimes am on my feet for 12 hours, like just trying.
And it is not just you, you also have a team with you.
We have a team, just not just me. It is me. There will be 1 or 2 assistant surgeons who, when I'm leading the team. We have scrub staff, we have anesthesia colleagues, there are usually 2 of them. We have other runners in the theater. And then that is just in the theater when I'm doing the surgery. But then these patients are shipped on to the intensive care unit where the intensivists and the nursing staff on the intensive care look after them. And when they go out of the intensive care, it's the ward staff, the physiotherapists, the occupational therapists, and different psychological support is needed for these patients. So it's a very big team who looks after these patients.
But how do you manage to work 12 hours straight doing a surgery? Isn't that mentally extremely taxing for you? I mean, physically, of course it is, but...
The thing is that I think we get trained to doing it because it's not the first time we have done. So I think it's just you get conditioned about it.
Mm-hmm.
I can be wide awake for those 12 hours, but when I sit down on a chair, I can just go off to sleep. So I think it's just how we are conditioned. Basically, I can't say anything else. And you get trained. We do this training before we set out on our own for many years.
Absolutely.
I think that is what makes us, primes us to do these surgeries.
True.
Then it's to take the whole team on board and make them actually work with you in such a long period of time as well.
Right.
It's not just me who has to be there.
Right.
So it is, So there are times during the surgery when we can take a short break and just rejuvenate ourselves, put our legs up for 5-10 minutes and then go back to the table. So there are opportunities to do that. Right. And one good thing about particularly my unit and many other centers in the world is that we work together with all my colleagues.
Right.
So I can always phone a friend and tell them I'm tired and can you come and take over the surgery and complete.
That's nice. Very rarely you may do it, but at least if you really need to do it, you can. Okay.
We don't feel shy of doing that.
Right. No, because, people generally don't understand what a surgeon goes through inside the, OT, because we are always, as from the patient's point of view, we are always so tense about, things going wrong or, what's happening. But we don't even think about the surgeon's perspective that, what they go through inside while doing a surgery. So that's why I wanted to know that, what kind of challenges you face. So there's also this myth about, that if I go through a heart surgery or if I go through a heart transplant, I will not be able to live a normal life after that. I have to have a very restricted life. Is that true?
That's not true at all.
Mm-hmm.
Apart from a few surgeries, I know people think that heart surgery is always life prolonging.
Mm-hmm.
A lot of heart surgery is done for symptoms rather than prolonging life.
Okay.
So
prolonging is just a byproduct.
Prolonging is a byproduct, But primarily, a lot of heart surgeries are done actually, if you see, we do surgeries for 2 reasons.
Right.
1 is to prolong people's lives.
Right.
And 2 is to, improve your symptoms.
To improve your quality of life.
Yeah.
Right.
So heart surgery is like that. It's a palliative type of surgery. And particularly bypass surgery, because people get worried so much bypass together. No. Bypass surgery is, most of the times, it's a lifestyle surgery. And there are very few indications in bypass surgery. If the blocks are at very origin of the tubes, that's the time they can prolong life. Or if the heart muscle is very weak and they can get it better and prolong people's lives. Rest of the time it's more to improve symptoms and improve quality of people's lives. And that is important to put it across to the patients that I want my patients in 3 months to be doing what they were doing before they were unwell.
Okay.
And so that is for cardiac surgery, because transplantation is slightly separate.
Right, I understand. Right.
Despite that, we have patients who take part in transplant games.
Uh-huh.
They are doing skydiving, they are doing whatever. It's not, you have a lot of medication to take in transplantation, but again, transplantation is done to improve your symptoms and prolong your life significantly, and quality of life as well. So all these patients, after going through a period of rehabilitation, they should all strive to lead normal lives. It's not get stuck to the bed kind of surgery.
That's nice to hear. So what are the advancements in heart surgery field that really excite you nowadays?
what excites me in my practice, I can say there are other things I can allude to them later on.
Perfect.
In my practice, particularly for heart transplantation, we have come a long way, particularly with the advancements in our organ preservation techniques
Okay.
and how we are expanding the donor pool.
What do you mean by organ preservation?
Yeah, I'll just first explain about the donor pool expansion first.
Fine.
Now, there are two types of organ donors, human organ donors. One is the donors who are brainstem dead.
Right.
And their death is certified because they can't breathe and they're neurologically certified as dead. But there is another category of patients who are called donors after circulatory death. These are the patients who have actually sustained irreversible brain damage. They will be like vegetables in the bed most of the time. There's no evidence that they will recover from their brain damage. They can't be certified brain death till we don't withdraw life support. They can't be certified death. So these are called DCD donors, and that has become a new pool of organs for heart transplantation.
Okay.
And other organs as well, lungs and liver. But heart transplantation has, like in UK, in the last 5 years, we have increased the number of heart transplants by 30% by using the DCD donors as well.
Okay.
Now, the difference in the two is because in DBD donors, we have a controlled way of, procuring the donor heart. And then we preserve it usually in cold, ice cold saline or in saline, which is about 8 to 10 degrees. So that is the advantage. And before procuring these organs, we can actually assess them very well. Whereas for DCD hearts, once the patient is passed away, then only he becomes a donor.
Right.
And we have literally, after he passes away, about 30 minutes to actually get the donor into the theater and rapidly open the chest, get to the heart, and put it on a machine called organ care system. And we actually give oxygenated blood to the heart and make it beat in a machine, and then we assess these hearts whether they can be transplantable or not. So that has been the recent advancement, and I'm very fortunate to be working in the institution which kind of led all the lab research about that.
Okay.
Yeah, so we are known, like Papworth Hospital where I work in Cambridge is known for DCD heart transplantation. So we have increased. So that is one exciting field. And there is more and more what we call as ex situ perfusion. So we want to see how we can preserve these hearts for longer. Because one of the limitations in heart transplantation is that you can keep the heart only without oxygen and blood for about 3 hours very safely, 4 hours safely. And after 4 hours, we see that the mortality in the recipient population increases.
Okay.
So we are always time pressed. When I'm doing a heart transplant, I have big time pressure that I need to start joining the tubes together so that I can start perfusing the heart again within that stipulated time. But we are developing newer devices now with the industry where we can keep these hearts safely preserved for 6 to 8 hours. And in an odd case, it's been up to 12 hours now.
Okay.
So you can get hearts from further afield, like, the travel distances are there.
Right.
So you can, obviously, all this equipment is very expensive.
Of course.
So it's not very easy to adapt it into every healthcare system.
Of course.
But this is the advance, and I think more popular they become, the costs will become less and more people can get benefited by that. So that is like advancement. When you come to cardiac surgery, the advancements at the moment is basically what we are tending to do is more minimal access surgery.
Right.
Instead of having a big cut through the breastbone in the front of the chest, people are trying to make smaller holes on the sides and around so that we can do the surgery through small holes and achieve the same thing that you would do by actually opening the patient completely. And also there is an increase in the use of robotics in cardiac surgery as well.
Right.
So these are the exciting things that happen. But still, just to reassure people, the majority of the surgery in the world is still done through a big incision. And when we do studies about pain and other discomfort, going back to work, I think at 6 months, most of these patients are equal in all the studies. So it may be that open surgery takes time to heal. Patients have pain after the surgery, but once they go through a period of rehabilitation, and that 6 months, more or less, they all more or less achieve the same things what they want to achieve with the surgery. minimally invasive surgery is not very prevalent, to be honest.
Okay.
Even it's still, I would say, most of the heart surgery is still done through a bigger incision.
Yeah, I mean, I think it is better to be safer and give better results or better outcomes. That becomes much more important.
That's very correct, because I think the most important thing in doing any surgery is whether you do through minimal access or you do through open surgery is to actually deliver the operation you plan to do.
Absolutely.
So if you can't do that, then it defeats the purpose of the surgery.
Absolutely.
So incision, as I said, it's a bit of a pain for the beginning.
Fair.
Once it heals, it makes no difference. So most of the people, like my patients, I would talk to them and all, important things are that, that they should get well. Their operation should serve them the best, and it should be done the best way that surgeon is competent to do it.
Right, absolutely. What are the common misconceptions which people have about heart surgeries or heart transplants, and how would you dispel those myths?
Yeah, so the important thing is to be honest with the patient and explain to them.
Right.
The fact that you can't take away is that every heart surgery carries a risk. And when I am consenting my patients, I tell them about two life-altering risks. One is risk to life,
right,
and two is developing a disabling stroke. That is the inherent risk of cardiac surgery. But people have to realize that most of the common surgeries like bypass surgery, valve surgeries we do, the risk is less than 5%. So,
But the risk still exists, and people have to accept that.
They have to accept that. Because if somebody tells them that there is no risk with the surgery, that's not true. They're not telling them the truth. So once you start telling the truth to the patient,
right,
that removes a lot of misconceptions about the surgery.
Right. That is also going to remove a lot of expectations from the people, which is a wrong expectation actually, which later can create problems or friction between the surgeon and the patient or patient family unnecessarily. You need to be upfront right in the beginning.
That's right, because when you're consenting the patient,
right,
the best thing is you need to tell them that this can happen. It does two things. One, you said that it kind of tones down the expectations, but it kind of prepares the family because they've already been informed that this is a possibility.
Right.
So it doesn't come to them like a surprise because doctor said kuch bhi nahi hoega, like we usually say.
Yeah.
And then something happens and heart surgeries can cause major complications. Like
absolutely.
I said, if there's a stroke afterwards, what's the point? The heart is beating well, but the patient has got a stroke. So we do explain, but again, these are 1-2% chance of it happening to most of the patients who are below 60 years of age.
Right.
Most in planned surgery. Obviously, in acute settings, the risks are higher. But in planned surgery, there are various scoring systems. If you look at them, we have these risk stratification models, and you can actually tailor the risk for each patient. And you can tell them that if we took 100 patients like you, one of them would die. One of them would have this complication.
Right.
Or two of them would have this complication. So that they understand that what you're telling them is a fact and truth. And I can tell you most of the patients, if you ask them, like I ask them sometimes, that if I gave you an odds of 99-1, would you bet your money on that? He said, yeah, I would do that.
Exactly.
So it's not very tall, but at the same time, you can't take them completely away.
Right.
And so that is one thing. And once you can break that ice, I think all the patients, that's one thing. Second thing is that you have to make the patient understand that their operation may be life-saving, but it is to improve their quality of life as well. I worked in India and my aim used to be that I want patients to go back to work after the surgery.
Right.
Because otherwise, healthcare costs in places like India can have a lot of implications on the family.
Absolutely.
And the individual itself.
Right.
So they should be encouraged to go to work. There may be an odd one who cannot go to work for whatever reasons.
Right.
But if the only problem is that they had a block in the heart, right, they had a heart valve was not working very well, and everything else is fine. Once this is done for them, I think
they are completely fine to get back to work.
It's normal. It's a mechanical problem. It's not a prolonged disease.
Exactly.
Once the mechanical problem is sorted out, it's like a car. You can take the engine is there.
Right.
Some part is not working. Once you put the engine right, people keep going. And then so there isn't any reason why they can't drive the car. And same with your heart and your human life. That the engine is fine. Just carry on using it.
Right. Absolutely.
That's what I tell all my patients, and I want them to go. If my patients don't go back to kind of reasonable quality of life, sometimes we feel it's a sense of failure on our part as well that we've not been able to do it for them.
So what are the kind of lifestyle changes which a person can do prevent landing up in a situation where they need a heart surgery or they need a heart transplant, So I'm sure there are certain lifestyle changes.
Very much so. when I was working in India, what I find is that I'm an Indian as well, and I could be guilty too. We don't pay so much stress on our diet and exercise, and generally, like, weight management or controlling your diabetes once you have, because hypertension, like as you see yourself, you deal with these patients all the time.
Yes.
I think when I was working in India, I used to tell them that my patients, you don't need to see me. Can you see Dr. Kapoor, who was a diabetologist,
Right.
for the rest of your life, so that your diabetes is in control. The important change that I tell my patients to make is simple things like make sure that your diet is altered. You eat less fatty food, eat more fiber, and have some fruit. That's one thing. Two is control. Go to your doctor. Go to your family physician who can look after you. Go, whether you're feeling well or unwell, every 6 months you should go to see your diabetes is under control, your blood pressure is under control. There's no
Yeah, people don't take these things seriously unless they land up with the complication.
Yeah.
That's the unfortunate part.
That is the problem, because if you can prevent that,
Right.
which is called primary prevention, if the primary prevention is strong, I can't say that nobody will get unwell, but less and less people will get, because many of these, particularly coronary artery disease, like where the heart tubes get narrowed down, that has got a lot of genetic component to it as well, as is cardiomyopathies we were talking about earlier on. But there are some things you can prevent, there are some things you can delay.
But at least we can catch them at a much earlier stage and then treat them
that's very
earlier, so that we don't have to land up with major surgeries at a later date.
Not only the surgery, even if they land at a major surgery, once the heart muscle starts becoming very weak, then the risks in surgery, the prognosis is much less better than if it could be done before the heart muscle starts suffering or scarring is there, or one develops a major heart attack. So that is the time you can still need these things by regular checkups.
Absolutely.
I'm not saying people have to get paranoid. A good checkup is that you can just go for a regular walk, and if your symptoms are fine, you don't need to. But if you start getting a little breathless, or you start getting a twinge, and a lot of times what I've come across is that sometimes heart-related pains, they can be anywhere in the chest or in the stomach, also at the upper part of the stomach, and they dismissed as indigestion and gas trouble and all that, and then they keep treating your gas trouble till they'll end up having a major heart attack.
True.
If you have various risk factors, like if you are a diabetic, if you have had family history, if you are a smoker, if you have high blood pressure, or your cholesterol levels are high, these are risk factors which predispose you to coronary artery disease. If you have any of these and you start feeling like I'm getting a bit breathless which I was not getting 3 months back or 2 months back, or I'm getting a twinge in my tummy, the upper part of the stomach, or in my chest, then it's better to see a doctor. Nothing may be there, but if something is there, you picked it up very early, and you can address it, and you can lead a normal life for a very, very long time.
Right. We always talk about prevention being very important, but somehow people don't understand the importance unless they actually fall sick.
We have time for so many things. Every individual, there is if you can do a 20 up to 45 minutes of exercise a week, they're saying now. They're decreasing it. Intense exercise for 45 minutes. Even if weekend exercises you are able to do, it helps decrease the cardiovascular disease.
Yeah, whatever little you can improve in your exercise pattern, I think that will always help you in your health.
Yeah.
Right, that's the prevention part. So let's now come. I would really like to ask you about this organ transplant. What is the process?
Yeah.
How does it happen? Like from somebody who's a donor to somebody who actually gets it. What is the whole process like?
So, in every transplant program in every country, there is basically a central body. Like in England, you have NHS blood transplant, and we'll have a list of recipients. And then when a donor is identified in one of the intensive care units, there are specialist nurses, which is most likely in India, it's the social worker who does that work. They approach the donor family and say that, if they're interested in organ donation.
Right.
Once they accept the organ donation, then the whole cascade starts. From that donor, blood, like in heart and lung transplantation, we are mostly concerned by what blood group is, and that's all matching we do.
Right.
Very few
so that's
patients,
only matching you do.
Yeah, there's very few patients need more intense immunophenotyping and then matching that.
Okay.
But most of is the blood group match.
Right.
And size match. Two things we need to do.
Right.
because we can't put a very big heart in a small person. There will be no room for it to function.
Right.
Or a very small heart in a very big person where it won't cope with the
So an adult heart and a pediatric heart will be different, of course.
So the size. So once that is done, then we that UNOS or NHSBT hub, it will match the organ to various recipients on the list. It's different in different countries, but in England, what we have is that we have a super urgent and urgent list. Super urgent are patients who are actually on those pumps, which I was talking about earlier on. They need to transplant as soon as possible.
Okay.
So for them, so they will be matched to those. If they don't have any matches out of these super urgent and urgent, then they go to what we call as a general offering. So every center will be told that these are this is the organ. Do you have a recipient for this organ in the center? Once that is accepted, like for example, our center is done, then a organ procurement team, or we call it the organ retrieval service in this country, there is a fixed time when it will be organized at the donor hospital, what time the team is going to arrive to the donor hospital. So we take a big van with all the people and equipment there. So we go to the donor hospital, and then there is a formal handover, and we check the details of the donor and see that everything is correct, because we don't want to make a mistake. There's another life waiting on the other side. So once that is done, then the organ procurement process will start. As I said earlier on, we just do the assessment of the heart and see it's still good and can be used for transplantation. And once we have done that, we will at the same time, because then multi-organ harvest is usually the case. So abdominal organs are harvested from the same donor. So we need to have a good teamwork with the abdominal team as well.
Right.
We all work together.
So one person can give so many organs too.
Yes, yeah. We had in this country about organ donation is called Max and Kiara law. And I happened to harvest Kiara's organs, heart and lungs, and 6 donors benefited from that one child. She was only 10 years old.
Wow.
That is how much benefit
one person can give.
And keep on living in another body.
Right.
Which is so apt for our country, where we think the life never ceases. If you see our philosophy, Indian philosophy, we think life never ceases. It just changes the form.
Absolutely. So here it is actually happening.
Yeah.
It's actually happening. So from one body to different body, it is going.
It's still working. People to lead better lives. So you can't give a better gift than this to anybody.
Absolutely.
So once that is done, then there's a transport organization which facilitates all the transportation, and the organ will be transported on to the center where the recipient patient is. So we will always liaise the times and everything, so that we don't want this heart to be standing and wasting the time outside the body.
Absolutely.
As I told you earlier on, that we need to fix it. We need to perfuse, as we call it, like put the blood back into the heart within 3 to 4 hours. So we are ready by the time the heart comes to my center, I'm ready to start stitching it in. I'll do some initial preparations for the heart.
So the recipient is already made ready by that time.
He's anesthetized on the table, chest is open, and
it's just waiting for the heart
to come, and then we start implanting the heart.
So what is the time frame approximately from this whole process, from donor to recipient? Usually what is the time frame it reaches?
It's very different at different times, because it can depend on many factors. It's sometimes we go to a donor hospital and then we have to wait there because there's no theater availability. They have had an emergency, because one has to realize that at least in Europe, many times the donors are in smaller hospitals where they don't have many operating theaters and a big number of people like anesthetists on call or surgeons on call who can do that. But I would say the whole process from the time we start till the transplant happens, it's at least 10 to 12 hours, if not more.
10 to 12 hours. But that's also a very small time.
Small time.
One person, removing it from one body and actually placing it into another, and it's just about 10 to 12 hours.
Yeah, the whole process.
I mean, that's pretty fast, So,
but, because you have to realize that we have been doing transplantation here now for 4 decades. So the system is very organized and mature. There's a possibility that where in India, there are more and more transplants are being done. It will take time for the whole process to mature, so that it's a well-oiled machine.
Yeah, and India also, it is picking up quite well nowadays. A lot of people. I mean, the best part is a lot of people are accepting to donate their organs. That is one of the most important things. We are having more and more donors, and obviously we would request more people to donate? I mean, what is your opinion on that? What would you like to say?
I think what is the point in burning your body if it
Right.
has got organs that can be actually used for someone else's benefit?
Save somebody's life.
Save life, give them better quality life. They will remember you forever, whether they know who it is or not, because we're not supposed to reveal the
Absolutely.
identity, but it doesn't make any difference. In Spain, there is an opt-out system. Every Spanish citizen is an organ donor unless he says, I don't want to donate an organ.
Oh, okay. Wow.
But for
that
that,
is great.
obviously, that we need a legislation. But again, as I said earlier on, the society needs to mature. We don't want to have mishaps because of organ donation,
True.
like which pushes people to do wrong things to procure
That's true.
organs.
That's
So
true.
what we need to do is that we need to evolve more so that people understand the concept of donation and the concept of valuing life at the same time.
True.
And that is what I would say. I would say that every person who can donate organs should. It's like in life times when people don't mind donating blood.
True.
But when your life has got no meaning, that you are dead anyway, what's the point in not helping someone else? That's amazing that in your death you can help somebody. So I would recommend that every person should will to donate their organ.
True. And if the person doesn't have a will, the family members can do so?
In this country, yes. I don't know. I don't know.
Right. So that
laws in
depends
India.
on
It
the
depends on
country's law.
countries, yeah.
Country's law.
Like in Spain, the government can take charge of the body. You can't do anything about that.
Right.
You in the relatives, but in Britain it's a soft opt-out. We still seek relatives' consent to, even if the donor has said that he wants to donate, but they still want to seek.
What happens if the person dies at home? Is it possible still to donate?
With respect to, you can use some organs, like you can use lungs.
Okay.
And there's a center in Canada. They use up to 3 hours of. It's called uncontrolled circulatory death because it's not done under control.
Right.
Kidneys we can wait for 3-4 hours to harvest. So like kidneys can withstand lack of blood supply for a long time.
Okay.
But not heart, not lungs. But some organs can be used even if the patient is dying at home,
Right.
as long as the appropriate team is notified about it
Right. Right. And within that time frame.
within the time frame. Yeah.
Right. It was really great talking to you, and I'm sure my viewers will be having a much better idea about this. Thank you.
Thank you, Sagorika, for inviting me to talk on
Thank
your podcast.
Thank you. Thank you for tuning into today's episode. If you enjoyed the conversation and found it helpful, be sure to subscribe to The Health Talk with Dr. Sagorika Malik for more such insightful discussions. You can follow us on Instagram, and remember, you can also catch this episode and more on Spotify or your favorite podcast app. The links are provided in the description. We would love to hear from you, as your feedback will help us to bring you the topics that matter most to you and your family. So until next time, stay informed and stay healthy, one episode at a time. And don't forget to like, subscribe, and share this episode.